Hi, everyone. Good evening. It's 6 o'clock, so we'll go ahead and get started. Thank you for joining us for our second Stroke Month awareness event, The Road to Recovery Advances in Stroke Treatment with Dr. Janhavi Modak. We thank her for joining us and sharing her expertise with us on this important topic. So, with that, I'll turn it over to you, Dr. Modak. Thank you.
Thank you, Simone, for the introduction, and thank you everyone for joining us today for this webinar. So May is Stroke Awareness Month, and we would like to take this opportunity to discuss acute stroke, advances in stroke treatment, and address any questions that you all may be having about acute stroke treatment. So I have no financial disclosures. And our objectives for the webinar today would be, again, to know more about stroke and specifically focus on the endovascular treatment of stroke. So let's start with some of the basics. So as we all know, the human brain, it's a central organ of our nervous system. And it's a part of a complex organization where every part of the brain has its specific function. If you look at the brain cells, there are around 86 billion neurons or cells within the brain, and they kind of interact with each other, with what we know as synapses, and that's just the communication between these brain cells. Now, being an important or a critical organ, the brain does need constant supply of blood to derive oxygen and nutrients. And for every specific part of the brain, there is a corroborating specific artery. So this diagram here, it tells you about the internal carotid arteries, which we all know are the large vessels at the front of the neck, the vertebral arteries, which run through the vertebral spine at the back. And at the brain level, these have connections with each other. There is a interconnectory network, which we call as the circle of Willis, and that's how the blood vessels at the front of the brain connect with the vessels at the back. So then what exactly is a stroke? So a stroke occurs when a blood vessel supplying a part of the brain is either blocked or bleeds or bursts. So every 40 seconds, someone in the United States suffers a stroke. Every 4 minutes, a person may die of a stroke. And that's why it's really important to know like what the warning signs are, what are the symptoms if someone presents with a stroke, and what to do in such a situation. So it is also a major cause of mortality and morbidity worldwide. It's the fifth leading cause of death in the United States. It's also a leading cause of long-term disability. And if you look at like strokes in general, 87% are ischemic strokes and 10% are hemorrhagic strokes. And we'll look at that in more detail. So an ischemic stroke is when a blood clot or a blood vessel is blocked because of a clot that is sitting within the blood vessel. A hemorrhagic type of a stroke is where bleeding occurs inside or around the brain, and this can occur due to bleeding or rupture of a blood vessel. Again, the focus of our webinar today is going to be ischemic strokes. And it's important, like, so why, what do we do if someone is suffering from an ischemic stroke, and how do we treat someone? So during treatment, the most important thing is time. So timely restoration of blood flow is the key to better recovery. And we only have a very narrow window to achieve reperfusion. It's also important to know that only a select group of patients or people do qualify for acute stroke treatment. And that's why it's important to alert like the emergency medical services to know what the warning signs are so that you or your loved one can reach the hospital on time and get the necessary treatment. So again, we talked about the human brain, we talked about the 86 billion neurons, and this is just a picture to show us like how the brain cells are connecting with each other through synapses. And we have almost like 1,000 trillion connections or synapses within our brain. Here, the brain cells and the connections or the network is being compared to galaxies. And these connections are so vast that it's difficult even to fathom, like with our own brain, like at what degree are things going on in terms of the network, the communication, and the function. So, what's important here, and why do we say that time is brain, is because, say, for example, a blood vessel is being blocked by a clot. So, a minute uh, of delay in treatment can cost you almost 2 million neurons, or that's the cells that can be lost within a minute. That can correlate to loss of almost 14 billion synapses. If there is an hour where you're losing in terms of treatment, you can lose about 120 million neurons, 830 billion synapses, and that can potentially lead to an accelerated aging by about 3.6 years. Um, we'll go into more details about what a large vessel occlusion is, but these are big strokes. And in those situations, you can potentially lose up to 36 years in terms of accelerated aging. So it's important to know the signs and symptoms of stroke. And this is an easy acronym to kind of to diagnose a stroke at the community level. So, say you're having problems with your balance, you're having sudden onset of loss of vision in one or both eyes. You notice that your loved one has a facial droop. The arm is limping, or one side of the body, so that either the left side or the right side is weak, the speech is affected, then all these are concerning symptoms, and the T stands for time. So now it's time to call 911. Um, this pictorial just kind of goes through what the signs and symptoms of the stroke can be. And again, depending on the area that's involved, you can potentially have a different symptom constellation of presentation. So it's important to know that the right side of the brain, it controls the left side of your body. So if a stroke is affecting the right side of the brain, a paralysis will be seen on the left side of the body. In a similar manner, if the stroke is affecting the left side of the brain, you'll have weakness involving the right arm or the right leg. Usually, the left side of the brain is also the center for speech. So, typically, patients who present with strokes involving the left side may have problems with speech, they may have problems with communication, comprehension, and all those things should warn you to just call 911, go to the ER, and get checked out. We won't spend a whole lot of time on this because this was kind of discussed during our webinar last week. So we'll focus on the treatment options. So here, this is another pictorial which kind of shows how a stroke can be caused. So the normal carotid artery here is without any kind of plaque, and this is how a diseased carotid blood vessel can look. And potentially, a piece of plaque can break off from the carotid. It can go all the way up into the brain blood vessel, and it can block the vessel. Sometimes a clot can travel all the way from your heart, all the way up through these vessels, and it can potentially block one of the blood vessels. So, whenever we deal with strokes, it's important to understand like some concepts or terminologies that we typically use when talking about a stroke. So, again, this picture here is showing us a blood vessel that's going to the right side of the brain, which is blocked with a clot. Um, and the dead center of this area, it's called the ischemic core. And that's the region where you have irreversible neuronal damage or cell death. So essentially, it's the part of the brain where, even despite treatment, that part may be potentially lost or it may not be salvageable tissue. As against that, a penumbra is the region with reduced blood flow and which is at risk of infarction if blood flow is not restored. So, whenever we are dealing with a stroke, our goal is to save this penumbra, to save this salvageable tissue from completely stroking out. Again, this is another pictorial which tells us the same thing. So, normal cerebral blood flow is around 50 ml per 100 grams per minute. Within the very core of the infarct, this blood flow is typically below 10 to 12 ml per 100 grams per minute. And within the penumbra, it can be below 25 ml per 100 grams per minute. And our goal is to restore blood flow so that this green part or the penumbra can be potentially saved. As time goes by, the core increases to a point that eventually it can include the entire area. So the core grows and the penumbra is lost, and the entire circle will be the ischemic infarct or the core infarct. So we talked about blockage of a vessel. So what's recanalization? So recanalization is essentially opening up a vessel that's completely blocked. And the goal of recanalization is to restore blood flow to the tissue which is at risk. And what we just discussed, it's trying to preserve the ischemic penumbra. Um, there are two broad ways to do that. One is through intravenous treatment, which is known as IV thrombolysis. And the second one is endovascular therapy, which is what we'll be focusing on. But before we go there, we'll be talking about some historical aspects as well. Um, for if we don't do anything, so say, for example, the patient comes in, does not receive either of this treatment, does it mean that there is no chance that the vessel will open up? So that is not entirely true. Our body does try to open up a blocked vessel, and these spontaneous recanalization rates, they can vary from 5 to 30%, depending on the various literature. Larger blood vessels, what we call as LVOs, when a larger blood vessel is occluded, the chances of that spontaneously opening up, those chances are very low. Even if you go for IV thrombolysis, the rates can vary. If you look at literature, the rates can vary from around 15% to, in some cases, they say it can be up to 50% for spontaneous recanalization. And that's where the endovascular treatment kind of comes into play. And we'll look at it later during our webinar. So going into the historical aspects. So in the early decades of the 20th century, stroke care was mainly supportive. So we didn't have any kind of acute interventions. Focus was just to take care of the patient, maybe pray and hope for the best. And the other thing was, yes, aspirin was administered to focus mainly on prevention of stroke recurrence. And the number needed to treat in that case was 140. And that means if 140 people were given aspirin, we were able to prevent recurrence in one patient out of those 140 people. Um, 1958 was the year when thrombolysis was initially used in patients with a heart attack or myocardial infarction. And following those steps, we started using streptokinase in patients with stroke. But the dose probably didn't work out, and there were more complications than benefits from those treatment. So that kind of um, took a backbench. In 1995, so this was almost like 40 years later, IVTPA was studied, and this trial showed that IVTPA did benefit ischemic stroke patients, and that 30% were more likely to have a good outcome compared to those who did not receive treatment. This was approved by the FDA in 1996. And it's important to know that this was only approved for within 3 hours of symptom onset. Um, so if you again deal with anyone presenting with a stroke or a stroke-like symptom, it's important to know that when did they actually have these symptoms or when were they last seen normal. And that really helps us tailor the treatment for that individual patient. If, say, you are with your family, someone develops sudden onset symptoms, it's important to make a note at the back of your head that, okay, it was like 9 o'clock when this first happened, so that you can relay the information to EMS and to the physicians at the hospital. Sometimes patients wake up with strokes, and in that situation, it's important to know when they went to bed or when were they last seen normal. So as you can see that this medication was only approved for up to 3 hours within symptom onset. And subsequent trials were done, including like Atlantis, ECAS, NINDS, that confirmed the benefit of TPA or tissue plasminogen activator within 3 hours. And subsequent studies were done, which extended this time window to up to 4.5 hours from symptom onset. And this was in 2008. So again, it's important to note that for a significant period of time, IV thrombolysis was the only option available for stroke treatment. Again, this is a use of an intravenous clot busting medication, which is the first line of treatment. We talked about the 4.5 hours from symptom onset, and we also talked about how recanalization rates were lower in cases of large vessel occlusion. And if you look at the various medications, the first generation, which was streptokinase, did not work as well. The second generation was the one, the alteplase was used for the trials. And now we do have a third generation medication, which is tenecteplase, which is being used. The advantage is that we can give it like as a single shot without any infusion. It also has better clot affinity and penetration. So this is something that we have been using at Bay State now. And now coming to the endovascular treatment. So this is typically indicated for patients with large vessel occlusions. We know that only a few centers are equipped and capable to offer thrombectomy, and Bay State is one of those centers. So usually the procedure is performed in a cath lab or a neurointerventional suite, where you can see this big machine with two C-arms, a big screen, and then you can see the procedure table where the patient lays flat. These two C-arms, they deliver X-rays or radiation by which we can actually visualize the blood vessels, which you can like see here in the picture. So the way we typically do this procedure is we enter either through the blood vessel at the groin, or sometimes we can enter through the blood vessel at the wrist. And then under X-ray guidance, we go all the way up to the blood vessel within the brain, which is blocked. And this way we can try to retrieve the clot, which is occluding or blocking the blood vessel. So let's see if this will play for us. This is a video which depicts the thrombectomy procedure. So here you're looking at the blood vessels.
Position the balloon guide catheter as close to the thrombus site as possible. Connect a rotating hemostatic valve, or RHV, to the fitting of the guide catheter.
This
And
is
then
the
connect
blood
the
clot.
continuous flush. With the aid of a suitable guide wire, hold the
The
guide wire in
operator is
place and
taking
advance
the
microcatheter.
catheter into the vessel.
Position the microcatheter distal to the thrombus so that the usable length portion of the solitaire FR will extend past the side of the thrombus when fully deployed. Once the microcatheter is in place, remove the guide wire and tighten the RHV to secure the catheter. With the aid of fluoroscopic imaging, carefully advance the
And here
solitaire
we are
FR
advancing the
until the
device, which will
hooked up at the end of the microcatheter.
engage the
To deploy
clot.
the solitaire FR, loosen the RHV. Then carefully withdraw the microcatheter while holding the solitaire FR in place until the microcatheter tip covers only the proximal marker of the device. The usable length of the deployed solitaire FR should extend.
So essentially, the clot is interacting with this device, and we give some time for the blood vessel or the clot to kind of settle within the stent retriever.
The guide catheter to include the vessel. To retrieve thrombus,
And then we retrieve it by pulling it out of the blood vessel and out of the patient's body.
while applying aspiration to the guide catheter.
So some of these techniques, so for endovascular therapy, again, within this endovascular realm, there are different treatment options. And we looked at intravenous TPA being the first line of treatment. And initially, we all thought on those lines, and we tried to incorporate the same strategy and maybe hoping for, yes, this thrombolytic will probably also work within the brain blood vessels. And trials were done where the clot busting medication was locally administered inside the brain blood vessel, but the results were not too great. We did have issues with bleeding, and that kind of gave us a non-superior result in terms of when endovascular therapy was compared with medical management. Multiple trials were done, including IMS 1, 2, and 3, where in IMS 3, they actually combined IV treatment, IV TPA, with endovascular or intraarterial therapy, and that too was a negative trial. Then in 2004, this device came up, which was called the Mercy device. And you can look at it, it's a corkscrew shaped device, which again, the idea behind that, as you can see in this picture, is that it will engage the clot and it will help us pull the clot out. But again, with this device, there were more complications. The bleeding risk was high, and this kind of fell out of favor. Trials were done, and they failed to prove superiority of endovascular treatment over medical management alone. So again, we were still just left with IV thrombolysis being the sole treatment option. We then had the aspiration catheters, which were again FDA approved in 2009. So one of the first catheters was from Penumbra. And again, we have different devices or different companies which have their own aspiration catheters. And essentially what happens is, as you saw in the video where you took the catheter all the way up into the clot, and then you deployed a device. Instead of that, what this trial looked at was just aspiration or suction good enough to retrieve the clot. So the idea behind this was to connect this catheter to a suction pump, and it's almost like manually sucking out a clot. You can imagine, like if there's a pipe which is blocked, and if you use a syringe to suck it out, that exactly is what we try to achieve with this specialized suction machine. which can modulate like the pressure that's exerted on the catheter. And here you're seeing a picture of the clot which has been retrieved. The ADAPT technique is the name of this direct aspiration technique that was studied. And good results were seen, although the trials did not turn positive until 2015. And then we looked at the stent retriever, which was shown in the video. So the solitaire stent retriever was the first one that was approved in 2012. The Trevo, again, is a second company, which they have the stent retriever, which you're seeing in this picture. And here you can see a clot retrieved from a patient by use of the stent retriever. And this pictorial here, again, gives you an idea of how this works. So the central part is aspiration alone. This on the left-hand side is use of a stent retriever. And sometimes you can use both together, which is called the penumbra technique. And that comes from the solitaire and the penumbra. So those were the first two stent retrievers and the aspiration catheter that were studied here for stroke treatment. And so now, like this depicts as to the journey of what happened when we were trying to look at stroke treatment through the endovascular route. And all the way up until 2014, all these trials were done, which were either non-superior or were inferior to medical management alone. Up until 2015, when Mr. Clean was published, and that was the first time that endovascular therapy showed superiority over medical management alone. And again, there were various reasons. Some of those were patient selection. Some of those were availability of newer generation devices, which were safer, which were more efficacious. And all these led to good or even like great results, especially for patients who presented with strokes where a large blood vessel was occluded. And what was important is that they prove the efficacy also in terms of reducing disability post-stroke. So again, as we discussed, the trials proved that endovascular therapy was superior compared to IV thrombolysis alone. And the trials were specifically looking at large vessel occlusion in the proximal anterior circulation. And that means the vessels involving the carotid artery, the middle cerebral artery, which are the vessels in the front. They did not look at the vessels at the back during these trials. And these were the trials which were subsequently published right after Mr. Clean. So the ESCAPE, the SWIFT Prime, the Extend IA, Revascat, all these showed positive results. Here, it would be important to know that the number needed to treat, and that means to achieve functional independence, was 3 to 7.5. And that means for one patient to do really well, 3 patients had to be treated. If you recall from aspirin, it was 140, and this is down to 3 to 7.5 based on various trial results. So this is a significant improvement from what we were doing in the 1950s, I would say. This again gives you a pictorial which tells you how a thrombus is, or a clot is withdrawn through the blood vessel. And on this side, you can see a clot entangled in the stent retriever. And this is a busy slide, but this is a pooled analysis of all these trials, which look at different age groups, different risk factors. You're seeing aspect score, and that means like the area or the tissue that was already infarcted on the CAT scan. They looked at whether or not TPA was given. And all throughout the studies, they favored endovascular intervention over medical management alone. So now all these trials only proved efficacy for up to 6 hours from symptom onset. But what's unfortunate is that only about 10% of patients can present within a 6-hour time window. So almost 90% of patients present within 6 to 24 hours from their symptom onset, and these patients were not eligible for this type of therapy. And that's when people started looking at, researchers started looking at extended window trials. And that means, can something be done in this subset of patients where they are past the 6-hour window, but still within the 24-hour window? And the first study that was published was the Dawn trial, which looked at such patients. And again, it had great results where 49% in the thrombectomy group did well compared to only 13% in the medical management group. And here the number needed to treat was 3 to achieve functional independence. The second trial, or actually before that, so this tells you about the scores that we use for looking at the outcomes. So a score of 5 or 6 is a bad score. It's disability, and 6 is death. A score of 0 is normal. 1 or 2 are considered good scores. And you can see, just looking at the intention to treat population here, you can see more 0s to 2s in the thrombectomy group. In the control group, you can see these darker shades, and that means like the patients are not really doing as well. That means they're dependent on care, they are bedbound. 6 is death, so they did not survive. And you can just visually see the difference. Again, they looked at subgroups, and that was up to 12 hours. And even in that case, you can see more of these shades of 0, 1, and 2. 2 is just mild disability. 3 is when you need like a walker to ambulate, but that's still considered a better outcome compared to 4, 5, or 6, where you are, 4 or 5, where you are significantly dependent on care. And they even looked at 12 to 24 hours, and consistently thrombectomy or patients who underwent thrombectomy showed better outcomes compared to those who were just treated with medical therapy. And then the next study that came around the same time was this Diffuse 3. And they looked at patients who presented within 6 to 16 hours from their last known normal time. But even in this group, it's important to see that 45% of patients in the endovascular group, that means those who received thrombectomy, did well compared to controls. And the number needed to treat was again 3.6. So for every like third or fourth patient, 1 out of those did really, really well. And this is what we used for all these trials. So this was a special type of CAT scan study, which is known as CT perfusion. And if you recall, we talked about the core and we talked about the penumbra. So the core is the tissue which is already damaged or which is already infarcted. This is the tissue here that you're seeing in pink, where you have cell death. And then this is the tissue that you're seeing in green, which is the tissue that you can potentially save. And what these trials looked at was that if the core infarct or if the irreversibly damaged tissue was low, and if the area that could be saved was bigger, then those patients benefited from endovascular treatment or intervention. And so now going back here, so you're only for those Diffuse 3 and the Dawn trials, they did not look at patients who had larger strokes or a larger core volume on presentation. So here you can see the core here is 23, the perfusion is 128, and the mismatch is 5.6. And that just tells us that there is a larger tissue that can be potentially saved. what happens to those patients where a core is really high, say it's 75 cc's, and if the perfusion area or the penumbra is low? Those were the patients that were studied more recently in 2023, 2024 in trials, and we call those large core infarct patients. And that means they are presenting with large vessel occlusions. They already have a big stroke on the scan. Would they still do well if we offer them endovascular treatment? And the answer is yes. They do better compared to someone where we've not offered endovascular treatment. But it's also a physician judgment call. Some patients, if they already have like bleeding within the brain, then those patients can do poorly. These patients, because there is already a larger area that is damaged, they are at a higher risk of bleeding. But overall, these trials were positive as well. So just to recap, we started at 1995, where IVTPA was proven to be beneficial. 2013, endovascular therapy was still not superior to medical treatment. 2014 is when we had the first few trials where we could offer treatment to patients presenting within 6 hours. In 2018, we extended that time window to 24 hours from symptom onset. And today we are looking at large core infarct trials. So you can just see like over this past decade even, so compared to 2015, where we were not offering treatment to patients presenting past 6 hours, today we can offer treatment to patients who are within 24 hours and potentially even have a larger stroke on CT. So what are the future directions? We are looking at patients who have medium vessel occlusions. The trial was recently published, and it was a non-superior trial, but some of these trials are still in the process of enrollment. We are also looking at distal vessel occlusions, and that means smaller blood vessels within the brain. Can we safely go after those? That would be the question. So just to go through what the clinical process is, how do we select patients? So clinical evaluation is important, and we won't go into the specific details, but when someone arrives to the ER, we do quick stroke score evaluation, what we call as the NIH stroke score, and that gives you the severity of the stroke depending on what deficits is the patient presenting with. We then look at imaging. So we do a CAT scan, we do a CTA. We want to know that this is truly an ischemic stroke, that there's no bleeding involved, there's no hemorrhage. With the CTA, we want to look at which vessel is blocked. Is this a large vessel that we can go after, or is this like a smaller vessel or a medium vessel, which may be difficult to reach with our devices? And then based on that, we figure out whether or not this patient would be a candidate for intervention. The timeline of presentation is still important. The sooner you present to the hospital, the better your chances are in terms of recovery. So we are treating patients within 24 hours. In some select cases, we are treating them after 24 hours as well. But we need special scans for those type of situations. And it's important to know that even if you're not eligible for IV thrombolysis, you can still be a candidate for a mechanical thrombectomy. Again, no procedure is without risks, and these are the overall procedure-related risks, which can include like bleeding, which can include dissection or injury to the vessel, because we are traveling from inside the vessels. The outcomes depend on your patient characteristics, that were they healthy, what other issues do they have, when was the time to treatment. And then this is just the clinical workflow. Like you go into the ER, we obtain the scans. It is a team effort. It's not just a procedure-driven treatment. multiple teams within the hospital are trying to expedite your treatment. So definitely it's a team effort. We look at whether or not you're candidate for a medical management with IVTPA. Anesthesia will be involved. We'll bring you to the procedure room. The post-procedural part also is really important because by opening up the vessel, like we are recanalizing the vessel, we are restoring flow, but afterwards you still have to be closely monitored, and that job is done fantastically by our ICU team. Eventually, you go to the floor. The next big step is rehabilitation, and the importance of that cannot be. I mean, it's really important because you with rehab you're trying to regain all the skills that you've lost. So this is a significant focus in terms of recovery from stroke. Um, Talking or going into more details is out of the scope for our like short 1 hour webinar here today. But this again graph just tells you the importance of rehabilitation. Early rehabilitation is important. People usually say, oh, you've had a stroke, let's just take rest, let's not do anything, but that actually may not be the best approach. You need to keep moving on after a stroke. The more you do, the better you're going to recover. Your mood improves. So again, moving after a stroke is very important. And then these are just some pictures. Here you can see this is a patient presenting with a basilar artery occlusion, which is the vessel at the back of the brain. And here you're not seeing any flow. This is after recanalization, where you're seeing the blood vessels fill out completely. So compare this picture to the picture on the very right. And then this is another case where the blockage is at the vessel that goes to the left side of the brain. And this is after complete recanalization. This is again just to recap what we all discussed today. What's important here is that timely intervention, recognizing the signs and symptoms of stroke are important, and calling 911 is important. Don't try to drive yourself. Don't take your family in your own car. The best approach is to call EMS in any situation because they know where the closest hospital is. They know where the thrombectomy capable center is. In our case, like Bay State is a center where we do offer such advanced treatment. And that's why it's important to rely on the experts, rely on the EMS folks to bring you to the hospital. So just to summarize, there has been a paradigm shift in the management of acute ischemic stroke. Endovascular treatment is now at the forefront of stroke therapy, and this has just redefined our standard of care. Again, rehabilitation is important. It definitely leads to better clinical outcomes post-stroke. And as we've just seen, this field will continue to evolve and will continue to grow. Again, we'll probably be treating more strokes in the coming years compared to what we are doing now. So with that, I guess we'll be open to questions and any other thoughts that you've had.
Yes, thank you so much. And I realized I forgot at the top, I usually make an announcement about questions. So we will be taking questions using the Q&A function. Some people have been submitting through the Q&A function, but usually I try to let everyone know at the beginning. So there is still time if anyone wants to put their questions in, but we will start with the ones that we have here. So the first one I have is, are you always able to retrieve the entire clot? If not, are there any issues related to pieces that remain behind?
Yep. And this is a very good question. So usually we try to retrieve the clot in its entirety. You can imagine that we are manipulating within the brain blood vessels. So typically they say that 4 to 6 passes, and that means like 4 to 6 attempts at retrieving the clot is what we do on an average. We can continue doing that, but that just puts you at a higher risk of vessel injury or bleeding from the brain. So it ends up being the physician's or the operator's judgment call. If a majority of the clot is retrieved and if there's just a small piece that's left behind, sometimes we leave it behind. We are not going for a good angiographic picture. We are looking at the overall clinical picture. And again, this would be going into more details, but there is a score that we usually look at. It's called the TICI score. That's the thrombolysis in cerebral ischemia score. So a TICI 0 is complete occlusion or like inability to retrieve the clot. A TICI 3 score is complete retrieval of the clot and reestablishment of the flow. So we always aim for TICI 2B or TICI 3. The recanalization rates at Bay State are over 90 to 95%. So I think we are doing a good job here.
Great, thank you. Next question, how long does the retrieval take place and is the patient fully under?
Yes. So typically the procedure is done under general anesthesia. In some centers, you can do this under conscious sedation. We prefer general anesthesia because that gives us a more controlled setup. It's safe for the patient to be completely asleep. And in terms of the time for the procedure, it depends on how easily we can go up to the clot. Say you have an elderly patient, their vessels can be very twisty and it can take a longer time to reach that site of occlusion as compared to someone who has like more straight vessels and it may just be an easy approach to the clot. So it can be done as quickly as 30 minutes. Sometimes it can take up to 2 to 3 hours. So everyone is different and it depends on the anatomy. It also depends on if we are able to retrieve the clot with the first pass or if we need to do multiple attempts at retrieval.
Thank you. And next, why would someone get IV treatment instead of endovascular therapy?
So yes, that's a great question. Not all. So we talked about how the endovascular treatment is can only be offered in select centers. Also, endovascular treatment cannot be offered for cases where you don't see a vessel occlusion, and that means like you have stroke symptoms but you're not seeing an obvious clot, you're not seeing an obvious vessel that's blocked. But you still know that there must be a tiny small clot somewhere. And in those cases, IVTPA is administered. IVTPA can also help break down the clot. So say you come in with bad stroke deficits, you give the clot busting medication, and then you take them for endovascular treatment. And sometimes that can help loosen the clot. Sometimes it can help retrieve the clot in an easier manner. I would like to add that some patients do not qualify for IVTPA, and those are the patients who are on anticoagulant medications. So for someone who's on Coumadin, someone who's on like Eliquis, rivaroxaban, apixaban, those type of medications, IVTPA is a contraindication. We also have to look at some lab parameters before knowing eligibility for IVTPA or tenecteplase. So it is a decision that's been taken by the treating neurologist after looking at the labs, after looking at your clinical history.
Thank you. And how soon after stroke does rehab typically begin?
So rehab usually begins at the hospital itself. So in the ICU, while you are recovering, you'll be seen by the physical therapists, you'll be seen by occupational therapy, speech therapy, and they start working with you. It may not be as intensive like while you're in the hospital. Definitely, depending on how much a patient can do, they eventually go to what we call as an acute rehab, where they can participate in intensive therapy, or like subacute rehab, where the therapy is not as intense, but you still get to work with PT, OT, and speech therapy. So it starts like right at the hospital, and it continues like even if when you're discharged from, say, you're in an inpatient rehab, you still should be doing outpatient therapy. You're discharged from your outpatient therapy, you should still continue to do exercises at home, because all this leads to significant improvement in your outcomes.
And is any imaging done after the procedure or during recovery?
Yes, so definitely, once we do the procedure, we are monitoring the patient in the ICU. We want to make sure that the patient has not had any procedural related like complications. So we typically try to get a head CT within the next like 6 hours to 24 hours. We also get an MRI of the brain, and that tells you the extent of the stroke. So that tells us like, were we able to save the tissue that we were trying to save? Or did it end up being a large stroke despite a good recanalization? And I would like to like add to this that recanalization is just one aspect in this like whole scenario where you're presenting with a stroke. S- So even if you achieve good recanalization, if the clot has been sitting there for a very long time, it may be unfortunately sufficient enough to cause a greater area of damage. And the MRI does help with telling us the exact extent of the stroke.
Thank you. And if you're not near a center offering thrombectomy, can you do anything to minimize brain damage?
Um, this is also a great question, and that's why like EMS comes into play. So they do a quick assessment at the site or on scene, and they try to figure out like where should this patient go in order to get the best possible outcome. They may be able to take you to the nearest ER, where they can then even transfer you out by air or by ambulance to a center that is capable of doing thrombectomy. It's important to still go to the local ER or the one determined by EMS, because they'll at least try to stabilize you. They'll try to give you the initial like, clot busting medication. They'll do the basic imaging, which is needed. And at the same time, they'll be coordinating with these centers to try and transfer the patient for higher level of care.
Thank you. And this is the last one we have as of right now. You had mentioned at the end that you think you'll be treating more strokes in the future at Bay State. Why is that?
Yeah, so as we saw that the treatments are evolving, like we are getting new devices, we are getting better devices. And today we are not treating strokes with what we call as distal vessel occlusions. And that means like extremely tiny blood vessels, which are too far out to reach. The devices that we currently have and the trials that are currently ongoing, they haven't proven safety for such treatment. We are still waiting on those trials. So in the future, we may see good results. And then we could go after even smaller vessels. We could potentially go after longer times. That means over 24 hours, which currently we are restricting ourselves typically to 24 hours, and only in some select situations we are going over the 24 hours from symptom onset.
Thank you. And actually, we had another one come in. Is there any research being done on reviving brain cells that die due to stroke?
So there are, and that's a really interesting question. There are trials coming out, and I mean, they are still in the phase of research, which are called STEP trials, and we are looking at different adjunct medications that could be potentially administered at the site of ischemia. People have been looking at like stem cell treatment. So all these trials are still ongoing. We still don't have anything that's clinically being done, but I think in the near future, we definitely would be seeing more and more positive results. So I think it's a changing field, it's a growing field, and definitely with this type of treatment, I think we'll be helping like more people in the community recover from stroke.
Yeah, absolutely. That's encouraging to hear that that research is being done and that there's always evolving research and treatment options. So that's encouraging to hear. That was our last question, I believe. Nope, sorry, there might be one more. Oh, no, not a question, just some positive feedback. Thank you. Some comments. This was very informative. So I'll echo that and just say thank you, Dr. Modak, for sharing this presentation with us and giving us all this great information about stroke for Stroke Awareness Month. And I thank you and thank you everyone for joining. Have a great night.
Thank you all for your valuable time. Thank you.